Okay. So basically, from our perspective, we're going to talk about the protocol for performing lung ultrasound today. And to keep it completely simple for all of you as my colleagues, I want to make this as simple as possible, as easy as possible for all of you. So the same protocol would apply irrespective of the machine you use. Same protocol would apply whether the baby is preterm or term with slight modifications. And really, from our perspective, what we want to do is follow a standardized 8-step approach. Now, we talked a little bit about the step-by-step approach last time. And what does it involve? Well, the first most important aspect is probe selection. We then, once we've selected the probe and the kind of decision to use it, we want to disinfect the probe. We then basically want to use settings to default the probe to the settings of a preset or a set function which we can modify. Once we've done that, really what we're going to do is apply gel to the probe and apply it to the baby. But just before I apply the probe to the baby, I want the baby to be positioned. And I want the baby to be positioned in the position that gives me the best, the good quality images. We need containment. If you're doing a lung ultrasound without a nurse, personally, if you're doing a lung or an echo without a nurse, you will struggle. I think it's really important that you've got somebody who's able to contain swaddle the baby, keep him comfortable. The containment is not just for the quality of your images. I mean, it's also to make sure that when you're doing an ultrasound, there is somebody who's got what we call as situational awareness of what's happening to the baby. You're doing an ultrasound, you're looking at the screen, how hard you're pressing with the probe on the baby's chest, what is happening to the vitals, really how comfortable the baby is. This can all be fed back to you by another person who's able to kind of have a what we call as a global overview, has got a helicopter view. And I cannot emphasize this enough because really for very sick babies, as Ruby ji has kind of highlighted, you may not be able to move them. You might have to very carefully do the lung ultrasound scans, but the way you're doing it, you move, you could easily knock a tube out if a baby is intubated and ventilated, and that'll be a disaster. After you've kind of done your positioning containment, applied the probe, the next step is basically doing your lung scan. And we do it in a certain anatomical kind of distribution, which we'll talk about today, which is called partitioning. So there is a 6-segment lung ultrasound scan and a 12-segment lung ultrasound scan. And then there is relatively new protocols which talk about anterolateral scanning for lung ultrasound scores, which basically say that we only do R1, R2, which is right upper anterior, right lower anterior, and we do one lateral section, which is either R3 or R4, and we do the left side, which is again upper anterior, lower anterior, and one left lateral. So if you do these 6 areas, you can do a lung ultrasound score, which can give you an idea about really whether a baby has got a score that needs surfactant. And then we're going to talk a little bit about reporting. Now, why is it important from our perspective that we use a lung ultrasound protocol? Well, the most important reason is if you're using a standardized protocol, it's the same protocol that everybody's going to use. So really, when you do the scan, there will be documentation of the scanning indication, really what kind of imaging protocol you've used. When I talk about an imaging protocol, there are 4 things that you describe. It's the frequency of the probe, the depth you're using, and really whether you're doing purely an anterolateral scan, as you might do for a collapsing baby or to kind of diagnose a pneumothorax, or whether you're going to do a comprehensive scan, which is anterior, lateral, and posterior. And then what I would say is the third scan is the extended scan. And the extended scan is anterior, posterior, lateral. So 3 segments. And then because you need to, you're going to have to do each individual intercostal space. Now, just remember that that's quite a comprehensive scan because when you're looking at intercostal spaces, you're looking at front and back. And really, it's going to take some time. And there is a risk if you do scans for very long using lung ultrasound that in animal studies it's been shown you can have pulmonary capillary hemorrhage. So you need to limit your scans to a maximum of 2 to 5 minutes. In a sick collapsing baby, 90 seconds, really. And again, I will show you with practice how you can do that. The second aspect of using a protocol is you're using a standardized image. Just remember that it's quite crucial from your perspective that When you're using a standardized image, you're using the same terminology. So when I'm talking about R1, R2, I'm talking about the anterior right part of the lung. When I'm talking about R3, R4, I'm talking about the lateral part of the lung. But when you describe that, if you're using a standardized image protocol like that, when the next person does those images, he uses the same protocol. And actually, you can compare the scans side by side. You can compare R1 with R1, R2 with R2. And that is a beautiful way of being able to do serial lung ultrasound to see how your lung disease is evolving. Now, naturally, if you're using different terminologies and you start using, well, I'm going to use right lower lateral, I'm going to actually do a comprehensive 15 region view, and the next person is going to do a 6 region view. There's going to be a different standardization of images. Your interpretation will differ, and you will not be able to compare like with like. The third aspect of the protocol, which is something that I'll talk about next week, is using what we call as standardized terminology. So we have talked about A lines, B lines, C lines. Today we've seen what Z lines are, and we've got an alphabet. We also have to talk about pleural sliding. We have to see whether there's consolidation pleural effusions, and we have to see whether there's certain lung signs. But the most important thing is we talk in terminology using profiles. So fully aerated lung anteriorly with sliding and A lines, laterally with sliding and A lines, posteriorly with sliding and A lines means that the whole lung on the right and the left is aerated. So we basically call that an A profile. An A profile basically means that you've got sliding in all areas and you've got aerated lung. As soon as you lose your sliding and you have an A profile and you get a barcode sign in one particular region, you basically then are talking about a pneumothorax. So if I talk about an A dash profile, I'm talking about a pneumothorax. Now, if my colleague did a scan with an A dash profile, put a drain in, and I repeat that scan 6 hours later and I can see fully aerated lung with sliding, that A dash protocol has become an A. So A dash profile has become an A profile. So that is what we talk about when we say we're using similar terminology. And it's quite important to be able to document and talk in those terms because you might have to quantify a pneumothorax. So how far did your A dash profile extend? Well, it was up to the posterior axillary line. That's quite a large pneumothorax from anterior to the posterior axillary line. Now I've got A profile in the R1, R2 regions, R3, R4 regions. So it's fully aerated lung. So my pneumothorax is resolved completely. Or I've got an A dash profile still persisting in R1, resolved in R2, R3. So we're actually just below the anterior exit. It's a small anterior pneumothorax. So it's quite important to be able to describe and use that terminology. And we'll talk about the lung nomenclature with the dictionary next week. Once you've got all your images, you've thought about your terminology for each lung segment. You have to store these images. You then basically have to review them and then you have to report them. But a protocol means that if you are storing the same images in the same pattern, the next person who reviews them can actually do the same scan and compare. And that becomes quite important medico-legally. Let's say somebody argues that you have developed a pneumothorax. So your pneumothorax after the drain has suddenly got worse. And you do uh, a lung ultrasound. Now, on your lung ultrasound, if you haven't stored the R1, R2, R3, R4 regions as clips, you can't see whether they're sliding or not. How do you then prove that there was a pneumothorax there in hindsight? Now, if you have to kind of sit up in court and show those images and they're only pictures, they're still images, they're not loops, it'll become difficult for you to actually convince your colleagues and the court that actually there was sliding and then pneumothorax was there. So just again, our standard protocol will talk about this. So steps, we select our probe first. We use the appropriate frequency. So 8 to 9 for a term baby. We will use 12 to 16 for a preterm baby. For term babies, we tend to use the linear probe with a long footprint. For babies under 30 weeks, I tend to use the hockey stick. It gives me decent kind of footprint and gives me a much higher frequency. Once I've decided which probe I'm going to use, I'm going to disinfect it. In our setup, we use Clinell wipes. There is also Tristel. I'll talk about that as we go forward. I then press on and basically decide to use my presets, my lung presets for preterm or term. Depending on that, it defaults to a certain depth. If not, I will choose the lung vascular or MSK preset, which defaults to a kind of a depth of 2. Press depth, increase my depth to 4. Apply gel, get the nurses to swaddle, contain, expose the baby. We don't want him to become hypothermic. So, and then start doing my scan and planes. Do a lung ultrasound score if necessary. Review my images, store them, and report them. 8 steps. We've talked about the importance of having good footprints. I cannot emphasize enough that this footprint in a term baby will give you a good 5 centimeters of chest. It will give you about 3 to 4 ribs, 4 to 5 intercostal spaces if you use the extended view, maybe even up to 6. If you use the normal view, it'll still give you 3 ribs, 4 intercostal spaces. Now, if you use this hockey stick in a term baby, you'll get about 1.5 centimeters of footprint. Can you imagine how many views you're going to have to take to actually get the anterior lung in a term baby? It's going to be multiple views, but when you use your M mode, you're going to have to put the M mode on in so many different views that it'll result in a very large number of images that need to be taken, which is a lot of handling for a baby who might be quite sick. So again, what I'd say is if they're over 30 weeks, use your linear probe. Personally, I love the linear probe. I don't mind using it even in extremely preterm babies once you know how to change the frequency. But yeah, the hockey stick will give you much better images if a baby's technically under 30 weeks, under 1500 grams. I'd start using the hockey stick. If neither are available, just remember you can use the other probes. You can use the convex probe and you can use the S89. The question that you're asking is very important. Now, at the end of the day, if I am doing a scan, I can even use the S6 if I've got that, which is a bigger kind of sector probe, which we use for echocardiography in my setup. But really, from if I'm doing a collapsing baby, and I need to scan everything, then my simple question is I'm not going to switch between probes and presets. That's going to take a huge amount of time. I'm just going to use the sector probe to do everything. And really, if I've got an S6 with a decent footprint and I'm looking for sliding, which is the most important thing, sector probe will suffice. You can also use the convex probe, but just remember from the last session, if you use the convex probe, you are going to get a very small footprint and your ability to kind of see the pleura is limited. Subpleural consolidations gets limited. Again, when I scan, I'll show you the difference between what images look like when you use a linear versus a convex probe. Once you've selected, use your protocol, but just a small question about how much disinfection should be done. As a bare minimum, you need to disinfect the probe and anything that's going to go into that incubator. Now, when I scan, I like to hang this area of the probe over my neck. It just gives me much better stability. And then I'm going to hold the probe, and a significant part of this is going to go into the incubator. Some of it will stay outside. So you need to disinfect a significant proportion of it. If time permits, look, if you're working in a 100-bedded unit, infection control is just as important as if you're working with a unit that kind of has 14 intensive care beds. There's no compromise over here. So in an ideal world, when I start using my machine, uh, we will take a Clinell wipe, wipe the screen, wipe the surface, wipe the body, including the buttons, and really disinfect the probe pretty much to the portion where I feel that is going to go into the incubator. So you you use Clinell that's allocated for the machine. Do not pick up a Clinell wipe that's being used for a baby who's on contact proportions and then start using it on the machine. We have dedicated Clinell wipes which we keep on our machine. Be careful when you wipe the probe. Do not use alcohol. We do not use alcohol to wipe a probe. And if you're using alcohol in India or spirit, just be careful. Don't keep it near something flammable. It's usually 90%, so it's very high concentration. The other thing that's used now is Tristel. Now, Tristel basically is a wipe that kills sporicidal kind of fungal, bacterial, and has got good virucidal effect. It has 3 wipes. One wipe, it's specifically designed for ultrasound machines, doesn't damage the probe. But more importantly, is something that basically uh, will kill everything. I don't know how well Clinell will kill stuff for fungus and viruses, but that's what we use. Tristel will kill everything. Tristel is quite expensive. So Just be careful. It has one wipe, which is basically a saline wipe, which basically cleans grit and dirt off this. So, if this has got blood stains or stuff on it, it will give you a really good kind of clean. It then basically has a disinfecting wipe, which needs activation. So you have a wipe that's separate to this crystal kind of foam. And once it activates, you get this very strong pungent odor. So you clean the entire kind of probe with it, and then really once it's dried, you have a third wipe which basically cleans off the disinfecting agent so that that agent doesn't come into contact with the baby's skin. Really good stuff, but not cheap. Just looking to see if we have any questions. So Mohammed has asked, do Z lines have any significance? No, actually they don't. They're just artifact, just like B lines. You want to look for B lines. B lines are reflective of interstitial fluid. A lines are reflective of aerated lung. A C line or consolidation profile means that the alveoli have got exudate within them. Z lines reflect an artifact of interaction with the pleura, which is just an extended comet tail, but more horizontally kind of directed. Uh, I would not give it any significance. But the reason you need to know about them is I don't want you to interpret Z lines as B lines. Otherwise, you may start thinking a lung is wet. In which direction should the pointer be, up or down? Anna, just what do you mean by that? Just so that I can clarify.
In every ultrasound probe, you have like a pointer, like one side that you use uh, this line on the lateral side. That I mean as a pointer.
Yep. So what I would say is that I'm just trying to stop using this. So when you look at the pointer is always cranial. So if the pointer is at the top end, it will always be cranial. So I have a picture and I'll be able to show you if I can just get out of this light, which is totally pissing me off now. Okay. Now, lung ultrasound presets. So what are presets? Presets, as you saw on the screen of Shireen, basically are presets for different organs. So when you look at any ultrasound machine, the company will basically put presets for a probe. So when you click on the probe, you'll come up with a profile that'll basically say vascular, musculoskeletal, brain, lung, heart. And really, what it's basically doing is setting to the depth, frequency, focus levels, as well as a lot of things, harmonics, interaction of, I would say, uh, gain settings, that is the ability to kind of increase echoes from the lung, uh, time gain compensation. All of these things are set so that they're fixed, these 7, 8 variables, to the best imaging that you would be able to obtain for that particular organ. Now, the lung is the simplest of all. Whenever you set your probe and you choose it, it will set to a preset that you can choose, which could either be muscle, skin, kidney, MSK, it's muscle, superficial as well. And you can also choose the vascular setting, which gives you a depth of about 2 centimeters. And all you have to do is press the depth button and increase it to 3 for a preterm baby. About 4 centimeters for a term baby, I feel is adequate. You'll get 8 centimeters, anterior to posterior. Laterally, you'll get 4 centimeters. It gives you a really good kind of an overview of the lung if you're looking at me. Now, just be aware that modern machines, when you use your preset, they tend to optimize in different ways. So a modern machine, an ultrasound machine, do I have an image here? Yeah. So when you look at this ultrasound machine, and these are the buttons. So that's the depth button that you can see over there. So when you choose your preset over here and you say, I'm choosing MSK or I'm choosing vascular, you press the depth and really you turn it clockwise and it'll increase your depth. So once you've selected your depth, your frequency button is usually over here. And really, your frequency will default to the frequency that the probe is already using. Now, as we saw, when you're kind of in the situation where you're using a curvilinear probe, you tend to have a frequency maximum or a linear probe of about 8 to 9 on a curvilinear. An adult curvilinear is about 6. But if you use a linear probe, you're kind of going to get frequencies of up to 12. So you can press the frequency button to change it up and down, and that will basically come up as quadrants. And again, I'm going to share a video with you tomorrow that shows you how to do that. But if you can't change the frequency, don't worry. Adjust your depth. So if you're getting dropout at the bottom, as we saw that we were getting in images today with RubyG, and you can't change your frequency, reduce your depth. Get the best possible image that you can for that area of the lung. The most important aspect is to be able to see pleural sliding. And really, that is good enough because really there's no reason from your perspective why, if the pleura is sharp margins sliding with an A-line profile completely, that you should have. There's no such thing as consolidations that arise below that. They always arise from the pleural line. The only slight risk is if you've got atelectasis and consolidation, that you might miss static air bronchograms or dynamic air bronchograms that are deeper. My gut feeling is that if you manipulate enough and you take good views, smaller views, you'll be able to get them. So don't feel too stressed about the fact that you might not be able to alter the frequency. You may have to be able to play with the depth. The only other thing that's very important from my perspective is that for those machines that don't auto optimize the frequency and the echoes at every level. So common modern machines like the Sonosite, the Philips, the GE, they will optimize echoes at every level. So if you have a kind of an image arising here, and if this is lung tissue and the ultrasound waves penetrate, you don't have focus. Why do you not have focus? Because the machine is beautiful. What it does is it sets its presets in such a way that it will increase the echoes coming back from the deeper tissue whilst allowing the same amount of echo to come back from superficial tissue. So you do not need to focus. The image is optimized for tissue at every level. If not, you can use time gain compensation. I'll talk about that next time to improve image quality. But really, from my perspective, with some machines, you will not have that auto optimization of echoes. And what might happen is if you use a very high frequency, the superficial parts of the lung will look very good, and you might not see the deeper part of the lung so well. So for that, you may have a focus. And if you have a focus, what you want to do if you want to see the deeper part of the lung is drop your focus down to the mid zone. If you want to see the pleura better, you might have to optimize your focus superficially. If you were using an old Fuji machine, or if you're using any of the old Sonosite machines or a very old Philips machine, you will have focal areas on it. You'll have a focus and you might have to adjust the focus. Okay, so step one was probe selection. Step two is disinfection. Step three is the preset. Simple. Choose your preset, adjust the depth, and then basically adjust your frequency if you can. If you can't adjust your frequency, you want to image optimize and you're using an old machine, adjust your focus. It's these three parameters that we're going to work with. There is nothing else you need to do. The one last thing, most of your machines, when you choose a lung ultrasound preset, it will turn harmonics off. At the moment, I can see that for the images that you're using today in all your machines, your harmonics are definitely turned off. Now, if you use an echo probe to do uh, a scan and it's using a lower frequency, it will have harmonics on. Now, the concept of harmonics is very important. Harmonics basically are an ultrasound mode that help to reduce artifact. So what they actually do is they, like I said, will tend to improve if you have harmonics on. They will tend to improve the ultrasound wave penetration and the echoes coming back so that you can see the structure of individual tissue. So they will reduce artifacts. So if your harmonics are on, they will reduce A and B line artifact. They might let your lung structure look better. But actually, by harding artifact, you might make interstitial appearance with large number of B lines not very visible. So just again, I'll let you know if your harmonics are on, but if you're using a standard lung ultrasound preset, your harmonics will be off. For all of you, please, if you have a technician, call them, use them. This is what you need to use them for. The next step is applying gel. Very important step. When you use gel, it should cover the whole of the probe. It should be uniformly applied. You don't want a massive amount of gel in the middle with no gel at the sides. Then you're going to have significant dropout. Just remember, when you use the surface and you press hard, the gel basically gets pushed out. It gets thinnest at the bottom, and the gel at the sides does not go into contact. And that is what basically creates dropout in your images. So when you're applying your probe, just remember your probe is applied by just keeping it in contact with the chest. The harder you press, the more your gel dissipates, the worse your image quality. So again, this is quite important from your perspective that you apply a uniform layer of gel throughout and that you apply the probe in such a way that the gel has uniform contact. That is why linear probes are so much better. You can see a curvilinear probe in a baby. It's not going to have as good a contact. For positioning and containment, you have to work with your nurse colleague. If you don't have a nurse colleague, can a parent who's there, if you're doing family-centered care, help? Explain what you're going to do to them, explain how they can help. Actually, having a parent there, using a dummy, using some sucrose. My personal view is where possible, if I want to do a scan, especially if I'm working up a baby for chronic lung disease, I like his tummy full. I don't mind it because actually it'll keep the baby in a quiet state. Swaddle the infant appropriately. You're going to have to expose this baby. So really, if you expose him like this, rubbish. How are you going to get into the axilla? You abduct the arm. You could have a real struggle. But what about when you want to turn him prone to do the back? You need to expose him. He needs to be swaddled comfortably. When I say swaddled, I don't want him swaddled in a towel that's covering him completely because that completely occludes the chest. I'm talking about gentle touch, handling, a warm environment. For a baby like this, I would almost always have a heating source at the top. When I do my echoes and I do my lung ultrasounds in babies like this who come from the postnatal ward, I'm going to have a heat source at the top. I want him to be nice and warm. I'm going to use preheated gel. I'm going to keep him comfortable. I'm going to use sucrose with a dummy. I'm going to keep my scan probe perpendicular, but I'm going to just keep it contact. I don't want to press too hard. The harder you press, the more difficult it is to do the scan. More importantly, from my perspective, I want uniform distribution of the gel. You place your baby in the position you find him. If I've got a sick baby who's prone, I will do the backs and the lateral regions, and I will do the front through the anterior axillary line. Similarly, for a supine baby, if he's very sick, I'm not going to turn him prone. I'm going to have to do the posterior regions through the posterior axillary line. For all babies who are extremely sick, just be careful about how you're going to handle them. Make sure they're positioning the tube. So you can imagine that if the neck is flexed and you have a tube that's basically interfering with your lung ultrasound scan, one move of your hand, you knock your tube and your tube might come out. So just have your positioning done beforehand. I've never had to use morphine or a sedative to get good images. Uh, I think unless you're kind of really worried that significant handling is going to destabilize a baby, most lung ultrasound scans can be done well within 90 seconds to 2 minutes. Supine positioning is convenient for the anterolateral part of the chest, but if you're going to have to do the back in supine position, you're going to have to scan by either getting the nurse to lift the baby a little bit, enough to not destabilize, or you're going to have to scan through the posterior axillary line, and that's going to involve a lot of manipulation. So, positioning quite important. Just examples of infant positioning, and then partitioning. So it's quite simple. We do scans, and I will always do scans in 12 regions, no matter how small or big the baby is. But some people and our colleagues, our French colleagues now want to do regions basically as anterolateral scans. So you need to know that. But how do we partition the lung for a six-region method? So you take a midline line, which goes through the sternum, and then you take a line which basically passes through the anterior axillary line. So this is the anterior part of the chest. Okay. This is the lateral part between the anterior axillary line and the posterior axillary line. And the back of the chest is basically from the posterior axillary line to the middle of the vertebral column. So that's the back, that's the posterior region. So what we're scanning is anterior, lateral, and posterior regions when we do a comprehensive perpendicular scan. We're going to scan all of these regions. Traditionally, and the Cactus Working Group, as well as my colleagues in the UK, tend to label these as right upper anterior from a line that crosses through the nipple. So really, this line here, this is upper, this is right, lower, anterior. This is right upper lateral, this is right lower lateral. And then basically the same line, roughly posteriorly, is right upper posterior and right lower posterior. Now, I'm a little bit brain damaged. I was born at 30 weeks of gestation. I'm 74 born. There was no surfactant, no CPAP. My mother says I had a decent amount of RDS. So really, with that amount of brain damage, I just this screws my mind up. Right upper anterior, right lower anterior. What the fuck am I talking about? I just get very confused. So excuse my language, but really, from my perspective, it's quite simple. I can label these by number, and the number basically is the easiest way for me to remember them. So actually, from my perspective, the nipple line extending from the back. This is R1, this is R2, this is R3, this is R4, and this is R5, and this is R6, and the same on the left. And you've got six regions. And I know what you're talking about when you say R1. You're talking about the right upper part of the lung. You're talking about the right lower part if you're talking about R2. But gradually, as you get more familiar with this, these are the standards. And this is the standard that our French colleagues use. And this is the standard that's been started to be used by our US colleagues. I'll share the article with you, which talks about simple numbering as a standard. The biggest advantage with using numbering as a standard is when it comes to reporting. You know exactly which region you're talking about. The likelihood of getting confused is very low, uh, especially if you're brain damaged like I am. That's the 12 regions. You can also use a six region method, and a six region method simply is quite simple. So for the six region method, what they say is that you are going to do R1 and R2 together, R3, R4 together, and R5 and R6 at the back together. Now, if you have a very small baby who's 450 grams, even if you use the hockey stick, you're really going to get R1 and R2 together. You're going to get R3 and R4 together. You're going to get R5 and R6 together. So really, from our perspective, for smaller babies, some people say that a six region scan is all that you need because you get the entire lung region. My advice is just stick to the 12 regions. Even if you're getting the two lung regions within one probe footprint. I will always stick to the 12 region scan. It's just easier to report. And really, even if I'm using an extended view, which gives me both of these regions in a small baby with one footprint, I would still report them separately. And the reason for that is you can see small pneumothoraces, which in the right upper region and the right lower region, even in small babies. So then really, if you don't use the 12 region scan, it can become quite confusing for how people report that. In addition to this, the only other thing that I want you to remember is when we talk about lung scoring, in which you do R1, R2, and you basically use one lateral scan. And that is what our French colleagues regard as standard. They do R1, R2, and they basically combine R3, R4 into one, and L3, L4 into one. So they kind of do split anterior, upper, lower, and just lateral. That's it. They don't do the posterior zones. And they are the gods. They are the people who trained me. I wouldn't question that. I think they're very good with their expertise. So just again, perpendicular scanning. So Anna asked, where does your probe marker go? Your probe marker is always cranial. If you're doing perpendicular scanning, so with a hockey stick probe, just remember the head of the probe is really where the marker is. With a linear probe, really, this is where your marker is always pointed upwards. Okay. So just if you are using and you are perpendicular, just remember you'll get good images. As you can see over here on the right-hand side, left-hand side, you got a nice image here with good A lines. Same image if you don't use the appropriate frequency and your probe is not perpendicular, you're going to get really fuzzy images. It's going to be very difficult for you to delineate exactly what's happening below. So you need to keep your probe in contact at right angles. This is what a longitudinal probe looks like. So again, so we talked about anterolateral scans, a comprehensive scan, So anterior lateral is just anterior lateral, comprehensive is anterior lateral posterior, and then we have what is called an enhanced scan, which is anterior lateral posterior perpendicular, and then you do each individual intercostal space. And again, basically you can see the pleural line, the rib with an A-line profile. If you're not using the right frequency, you will lose out. So you may have to drop your frequency a little bit, especially in term babies. It's quite deep. So a depth of 4 centimeters in term babies over here as well. Like if you're doing parallel scanning, the depth remains the same. Similarly, for preterm babies, the depth remains the same. You may have to change the frequency a little bit to kind of get slightly better images if you can. But if you can't, don't worry. Okay. What is Bradt score? Bradt score is basically a surfactant score that's done to try and determine uh, whether we need to give surfactant or not. And really, if you get a score in the range of 9 and above, for most babies, that favors giving surfactant. And I will talk about details of the studies and how we came to that conclusion. But to do Bradt score, really what you have to do is you have to look at the lung profile. So this is a lung profile that's aerated lung. This, you've got B lines. Can you see how sharp these B lines look? They're nice vertical lines. They're not Z lines. They go all the way to the bottom. And you have some aerated lung. So you've got a B with an A profile. This is an A profile aerated lung. This is a little bit wet. Here you have no A lines, B lines that are completely coalesced. It's alveolar interstitial edema, white out. But the classical definition for RDS is the presence of subpleural consolidations. So once you start seeing subpleural consolidations, what are subpleural consolidations? They're these white consolidations that you can see over here with no pleural line and atelectasis. Then really you've got consolidation. This is the worst grade of RDS. Now we know that RDS has a spectrum, hence using a score helps. And really what you do is you score each region R1, R2, and the lateral region using these scores, giving a score of 0 to 3. Now naturally, if you've got consolidation in R1, R2, and the lateral region, that is 3 plus 3 plus 3, 9 on the right side. 3 plus 3 plus 3, 9 on the left side, 18. I mean, that's a baby who's got very severe RDS. On the other hand, if you've got this kind of profile, an aerated profile in all these regions, 0, 0, 0, that's 0 on the left and 0 on the right. So that baby's basically got aerated lungs with no RDS. So the question is, why has he got respiratory distress? That comes back to, does he need NICO? Is there any other region? But Brad's score is the traditional score that we've used to give surfactant. And really, as part of reporting, you basically have to work that out in babies who are preterm to make sure that you're calculating it. We also know that lungs ultrasound scoring can be used to monitor RDS. It can be used to monitor. It's been used to monitor TTN as well. It's been used to monitor chronic lung disease. So really, knowing Brad's score is very, very important. We're doing a study on the use of steroids and lung ultrasound scoring at the moment, which is quite interesting. So once you've done that, you need to store images. Remember, you have to have a clip of R1, R2, and you have to have at least one clip of R3, 4. So for an anterolateral scan, you need to have 3 clips on the right and 3 on the left. They need to be loops so that you can see sliding. Once you've got those loops, really you have to look at them, you have to interpret them, and you have to report them. And it's important from our perspective that you use a standard reporting form. And I, for all practical purposes, will always report all 12 regions. I will always do what I call as a comprehensive scan, anterior, lateral, and posterior. My advice is always do it. You can scan the back through the posterior axillary line. And a standard reporting form will basically use a standard protocol that we call the lung ABCD protocol. It's called the Pleura ABCD protocol. I shared the article with you last week, but it basically says that you need to look at the pleura. You need to describe whether there's sliding or no sliding. You need to talk about whether the pleura looks normal or not. So continuous pleura that's bright, not thickened, less than a kind of a millimeter, with sliding is good. It's normal pleura. You then have to describe the profile, which I'll talk about next week. Do an M mode to make sure you have a seashore sign in all of those regions. And then you talk about dynamics. Dynamics basically means you're looking at the presence of certain aspects, comet tails. You're describing whether there's an element of Z lines, things that are moving that support your diagnosis of the fact that you've got an A profile. You then have to look at consolidation, atelectasis, and effusion. So you report this in all lesions. And that just means that if I've got fully aerated lung, like we saw with the first scan that was done by Hiba today, I had no consolidation or fractal sign anywhere. So you basically leave that blank. I had no dynamics anywhere other than comet tails. So I just ticked the signs where I saw comet tails. But eventually, if I look at Hiba's scan, it's an A profile with sliding everywhere with some comet tails. And the M mode was seashore sign. So it's well aerated lung. So my report is A profile in all directions. This is well aerated lung. Conclusion, well, the baby's respiratory distress is settling. He's completely in air. No further scans necessary. That's your recommendation. So a very easy performer for reporting lung ultrasound scans. You can make it as complicated as you want. Some people like to give descriptive kind of reports. So there are lung ultrasound reports in your kind of bank. This is really nice. This has been developed by the guys who wrote up the Pura ABCD protocol. So again, feel free to adapt what you want. The good thing about it is they include elements of what kind of respiratory support the baby's on. They talk about lung ultrasound scores, and if you have this can be adapted into a kind of a paperless online version that you can implement in Cerner quite easily. It's something that we plan to do over here. So it's your kind of thoughts around this. This is just a cheat sheet that I've shared with all of you today about what kind of frequencies you should use where, really for what weights, what kind of probes, and really the 8-step protocol. Any questions? Any que
I have a question. I have a question.
Yeah.
Here, Doctor, this reporting system, is it for every lung ultrasound or is it specific for RDS to give like Cervanta or not?
Okay. So the BRAT score?
Yes.
Yeah, the BRAT score is specifically used for diagnosis and management of RDS, but it has been adapted by a large number of studies to also look at it as a scoring system for management of chronic lung disease. Is it getting worse or better for prognostication? It's been studied as a score in improvement alongside consolidation when you're treating pneumonia. Rather than the actual score, I think what I find beneficial is what is actually happening with the lung, what's happening with the profile. But yeah, Brat's score is specifically used to treat RDS. There are lots of other scores. Robertson, Zemansky's. The Brat score is anterolateral. It does not look at the posterior regions. And that's my only grouse with it. Because I have seen bad RDS with subpleural consolidations with completely normal anterolateral lungs. And I think those are babies that might get missed if you're just using Brat's protocol and doing anterolateral scans. So I always recommend that you should do a comprehensive scan. Any other questions?
Sir, I have a question.
Yeah.
So when we are keeping the probe, suppose in R1 area,
Hmm.
do we need to move it laterally or be at one point?
Okay, that's a brilliant question. So what I would say is that when you use the linear probe and it is
Mhm.
penetrating 4 centimeters, it is giving you one cut section of the lung. But really, once you cover the lateral and the posterior regions, that's a good 3D view of the entire lung. So you do not
Mhm.
have to move it to the side because you're
Right.
getting the anterior part of the lung in that cut section, then you're getting the lateral part of the lung. So if I talk about the right lung, say for example, I'm just gonna go back to my slideshow. Sorry.
Because I saw a video from a team of China
Yeah.
and they were moving the probe laterally. So I
They
was
will, they
wondering,
will, they will. So when will you do that? So let me just bring the diagram up. So just give me a moment. Shit. Hmm, okay, I'm just going to share with you again. So can you see my slideshow? Can you see my slides?
yes,
Yeah.
yes.
Yes.
Okay. So I'm just saying that when I bring this slide up, so you can see my screen. So really, when you look at this, if I am doing this anterior region 4 centimeters depth, this lateral region 4 centimeters depth, and the back 4 centimeters depth, I'm getting a three-dimensional view of the lung, and I'm getting it from top to bottom. That's why perpendicular scanning is so much more informative. So I don't need to slide the probe here. If I've got a big consolidation here, between here, here, and the back, I will pick it up. But that's why it's so important to do a comprehensive scan. That's why I feel very uncomfortable with just saying just do anterolateral scans. You need to have a comprehensive scan. Where will I move the probe? So let's say in this baby, I've got a pneumothorax. So let's say I've got an air leak. Okay. Now, if it's an anterior air leak, I can see air leak over here, but we know that air rises anterolaterally. So if it's a large air leak, what I want to do is I want to move the probe so that I can see where the lung point is. And that's where I will move from medial to lateral to try and see where the lung point is. It doesn't always transpire that you can get good anterior views because of the heart over here. So you may have to move your probe laterally to get better views of L1 and L2 slightly obliquely. You need to keep your probe, but I might have to scan in the anterior axillary line. I might keep my probe like this. So there's going to be an element of manipulation for which you have image optimization, but you don't have to slide the probe, you know, 1 millimeter at a time to get the whole lung. Otherwise, you'll take hundreds of images. It'll take ages for you to take the scan. Does that make sense?
Yes, sir. Yes, sir.
Any other questions?
Yes, how
Yeah,
you do with the posterior scans when the baby is very sick? Because you
okay.
have to manipulate the
Yeah,
kid.
yeah. Okay. So you can see this image over here. So I've got the anterior regions. I've got the lateral regions. Now I've got the posterior axillary line over here. Okay. So what I might do is I might ask the nurses to move him a little bit, just a little bit, so that I can get into the posterior axillary line. And then I will scan, keeping the probe perpendicular in the posterior axillary line. And that will give me a good overview of the back. The most important thing from my perspective is that I have to be cognizant of the fact that I'm not getting the exact back of the lung. So there is a potential that I might miss an element of consolidation. And then it is the risks and benefits. Really, do the risks of moving this baby outweigh the benefits of picking up a small consolidation in a baby that's deteriorating? Now, if that's an acute deterioration and it's a dope, I want to rule out a pneumothorax. A pneumothorax is going to be anterolateral. It's not going to go to the back. If there is a small consolidation, I miss it, and I don't want to take a risk, I'm going to put him on antibiotics. Frank atelectasis, where you need to recruit lung of the back in babies who are chronically ventilated supine, you can do them through the posterior axillary line without any problems. So it's experience, it's time, but you can scan the back of the lungs through the posterior axillary line. Okay? Yeah.
Hello, doctor. I have
Yes,
one
Ravina.
question.
Yeah.
Yeah, today in one of the peer review, you have mentioned about mirror image sign and the truck sign.
Yeah.
So, what is the difference between these two? So,
Can
what
I
I
can I
understood,
yeah, yeah, go for it. Go for it. Yeah.
the mirror image sign would be the reflection of the pleura. Yeah.
Reflection of the pleura, yes. So the
Uh-huh.
pleura gives a bright reflection back.
Okay.
Okay, one sec. Let me Guys, for those of you who need to go, please go. Don't worry. I'll keep answering questions for those of you who aren't. I'm just conscious that we've exceeded our time, but I think some aspects are quite important for me to kind of cover. So I'm going to escape. I'm going to stop sharing. Just bringing up a photograph. Okay, I just want you to have a look at my screen. Can you see my screen?
Uh,
Yes.
yes, doctor.
Okay,
Yeah.
so a simple thing. You can see water over here, and this is the river or a lake. So can you see trees above and their image, which is a reflection below?
Yes.
Okay, now
Mm.
why is that the case? Because actually you have a difference between the density of light waves penetrating into the river because of different impedance, which is reflecting back. And because of the difference in that impedance, the higher the reflectivity, the better the image. Similar
Mhm.
aspect is happening with sound waves. So if I give you an analogy to say, this is the pleura, okay? Now, if
Mhm.
I've got alveolar air is not free air. So there will be an element of reflection from the pleura and a difference in the acoustic impedance. Now I've got rib over here, okay? This rib has higher reflectivity back, but the acoustic impedance between rib and pleura is also quite high. So there's an element of reflection back from the pleura, which means that the rib gets duplicated below the level of the pleura because of the reflection of these waves. We call this a mirror image sign. Now, when you have air in alveoli, there's no free air. If there's no free air, there's going to be less reflection. But once you get a pneumothorax, then a pneumothorax means that the ribs basically get duplicated above and below, and they look exactly like this. They'll be so bright that, like you see trees above over here, you'll see trees below. The ribs will appear above and below. That is classically called a truck sign. And if you see it so bright with no pleural sliding, then that is frankly representative of a pneumothorax. It's seen in about 30% of cases of air leaks. I'll show you some images in the next case. But does that make sense?
Yes, doctor. Yeah, it's clear now.
Any other questions?
Just a quick question.
Yeah,
I noticed that you didn't record the review session
you're
or
very
part.
sharp. You're very sharp. I forgot.
Okay, so it was
Yeah.
not supposed to.
No, no, no. I was supposed to. I forgot.
Okay. No
Yeah, I think,
problem.
yeah, I apologize. I'm going to apologize to the guys who've missed out. But I think today what all of you have got, and I'm just letting you know, guys, I know we have a total of 17 sessions. Like I said, in order to facilitate peer review for those of you who want, when you have enough scans, we can do one-on-one. I mean, for my colleagues from Portugal, probably a separate session. And it doesn't finish over there. Like I said, at the end of 12 weeks, you kind of do your testing. Your Microsoft OneDrive maintains a record of all your scans. You continue scanning for as long as you need. I will continue peer reviewing. And as I have done for previous batches, for images that cause confusion to you after 12 weeks, you can come back to me and say, Alok, I'm confused. I want to see a few images. So normally what we do is after the 12 weeks is over, we kind of go to doing peer review once a week. There's no theory in that. It's pure peer review. So once a week, we get all of you together and you discuss the scans that you want to. So this is an open-ended kind of what I would say handshake that I give you. If you want to scan and you want to develop the skill, time is not a factor for me. Your learning is more important. I'm happy to support you for as long as you want. But what I would say is there are, like I said, some people here who are pure voyeurs. They're here, they will, I have no problems with that. You learn in different ways. I respect all of you. But if you don't pick a probe up and you don't learn, then really it's a waste of this course and it's a waste for you because it's a very easy thing to be able to do, to pick up, to learn. And from my perspective, I cannot describe enough how important this skill is in terms of your ability to kind of look at a crashing baby. There are so many diagnoses that you'll be able to exclude just by knowing lung ultrasound. I mean, with the cardiac kind of, you need to exclude tamponade, you need to kind of exclude extravasation into the abdomen, acute fulminating NEC, a brain at an IVH. But there is more commonly, the most common reason that basically we lose out is we've either extubated accidentally and the tube's not there, or we've got a tension pneumothorax. That's much more common than everything else. And to be able to diagnose it with a lung ultrasound in 90 seconds, which is all that it takes, is a very, very valuable skill. So, any other questions? Last question. God bless you all, and I'm grateful for your patience. Going forwards will be more quick. Sessions will finish more quickly, but I'm grateful. I will share all the resources for the lung protocol with you. Just make sure you use it to the best of your ability. Thank you. God bless you all.
Thank you.
Yeah, good night, sir. Thank you.
Thank you.